I'm sorry. The mail they. Okay, yeah, so.
Alright guys, if y'all don't mind, we're just going to go ahead and get started if y'all don't mind eating and listening. For those of you that don't know me, my name is Carly Lassiter. I'm actually a student at Texas Women's University, but for the next few months, I'm DAPS's capstone student. I will graduate with my doctorate in occupational therapy, so I get to work with DAPS and meet all you wonderful people. We are so glad that you're able to join us today after all of the crazy weather last night. We want to thank Abbott for sponsoring the lunch and the great presentation we're going to get to listen to. I just want to remind you all that everyone is able to attend DAPS's classes. They're 6 days a week in person, and we also have virtual options. We have a copy of our calendar over here, and you can also access it online on our website. Next Tuesday, March 7th, is our monthly support group for anyone with Parkinson's disease, and Baylin leads that. Just to let everyone know, next month there will be no educational series in April. Everyone is invited to the Lifetime Achievement Award Luncheon in Dallas on April 26th. More information will be coming with that, RSVP, and more details. And then if you haven't signed in, I'll send around the sign-in sheet.
No, just happy to be here and to see everyone. As Carly said, my name is Baylin Blansochua. I am the DAPS Community Liaison, as well as a facilitator for several of the support groups. So very nice to be here with you all today.
So I want to introduce our speaker, Melissa Ryan with Abbott, and she's going to be discussing DBS and how to live your best life with Abbott. So thank you.
Thanks everyone. I'm so excited to be here finally. A little bit late, but better late than never. I'd like to thank, where's Paul? Paul with Medtronic with Boston to help you guys stay entertained until I got here. So I've been in the medical industry, pharmaceutical and device industry for over 20 years. Working clinically with patients and with clinicians in surgery and outside of surgery for patients therapy. So today I'm talking about Parkinson's disease, specifically non-essential tremor today, just Parkinson's, and how DBS therapy is an option for you and will help you get back to your baseline. So again, today's topics, what the symptoms are with Parkinson's. Most of you probably already know what that is. How is it diagnosed? What are those motor symptoms that can be treated, and how are they treated with medication and then also stimulation? And then DBS to manage Parkinson's. So we have about 7 to 10 million people worldwide that are currently living with Parkinson's, 1 million in the US. This just increased from 60,000 patients diagnosed every year. This just recently increased to 90,000. So within the last couple months, we got new data, and it has increased by 30,000 patients a year. Okay. We're also seeing an increase within the veteran population, their exposure to Agent Orange in Vietnam. There's a lot of chemicals exposure in different types of areas of agriculture. Those patients also are more exposed to potentially getting diagnosed with Parkinson's. So we're seeing an increase. It doesn't discriminate. So the typical onset of age is about 50 to 65. We do see younger patients that get diagnosed. We call that early onset of Parkinson's. The first symptoms are variable from person to person. Every brain is different. Every patient has different symptoms, and they come on at different times, right? A lot of times the first thing people realize that was a symptom of Parkinson's is loss of smell prior to COVID. And I always find that when people understand that, they're like, oh my gosh, I realized I lost my smell 8 years ago. You know, and then they progressed, and then they realized that was an early symptom of Parkinson's. It's slightly more common in men than women. Sorry, guys. But there's no social or economic or geographical boundaries, right? That's what I mean. It doesn't discriminate. And hereditary versus idiopathic. We don't know why it happens, right? There could be a genetic component to it, but again, there's really an idiopathic reason. We don't know. So what is causing these symptoms is the loss of dopamine to the brain. loss of dopamine producing cells. So it has a key role in your movement. That's what dopamine does. The interesting thing when we talked about the genetic and environmental factors, the loss of dopamine, once you have been diagnosed, you've already lost about 60 to 80% of those dopamine cells in the brain. So interesting how that is. But so this is an example of the DAT scan. This is one way that you can be diagnosed with Parkinson's. Has anybody gone through a DAT scan before? A couple people? Okay. Has anyone done the skin test, or is a skin biopsy you can do? No? Okay. So those are a couple different things, aside from doing your normal movement testing with your neurologist, and then they refer you over to a movement disorder specialist. Hallmark motor movement symptoms is obviously reduced voluntary movements. There's a slowness, right? Bradykinesia, stiffness, rigidity. Sometimes you may get dystonia. Your fingers or toes may curl up. That's also a symptom of Parkinson's. And resting tremor. Some Parkinson's patients are more tremor dominant, and some have more rigidity with no tremor. So every single patient is different. Non-motor symptoms, I just touched on the loss of smell, fatigue, sleep dysfunction, acting out in your sleep, constipation, and weight loss. So these are the pre-diagnosis, non-motor symptoms. This is early on, and it does vary from person to person, but then once you're diagnosed, you may start dealing with slowness, freezing of gait, rigidity, tremor, and then drug-induced dyskinesias. Once you've been diagnosed and they start putting on medications, as it progresses, as your disease progresses, you may have to take more and more medications, which could cause a side effect of dyskinesia. Does anybody in here experience dyskinesias? Yes? Paul? Yeah. I see that. No. So in addition to the DAT scan, which we just touched on, there's other ways to diagnose, which is the evaluation of your motor symptoms, right? And that's what normally maybe a general neurologist will do that, and then they'll send you on to a movement disorder specialist. Sometimes they don't. Sometimes general neurologists will just continue to manage you as well. The trail of dopamine replacement, which is like Ritari, right? The Cinnamon, or different medications to try to help you manage those on and off times. And the DAT scan, which we talked about. So, managing Parkinson's, there's very important components, and these are four of those. Diet, right? Really making sure you eat the right things and when you eat, because when you take your medication and what you eat prior to can impact the absorption of the medication in your digestive tract, right? So that's really important. Exercise, there is clinical evidence that exercising slows the progression of Parkinson's. Right, so there's so many courses or classes I see around town. There's yoga, there's boxing. There's a lot of things that you can do on a daily basis. Just getting out and walking around your neighborhood can help slow down the progression of Parkinson's. Just keep moving. Medication management, taking your medications on time is so important. And a lot of patients will set timers, they'll keep a journal or diary, but making sure you take it routinely on time really does impact your overall well-being. And then the advanced therapy we talk about with DBS, right? That's when you find the medications are still providing you some benefit, but not at the same level as they did initially. And then you start to have to take more and more medications, which causes side effects of dyskinesia, right? And this is just a nice little picture here that talks about the dopamine, levodopa. When you add levodopa, you add a dopamine agonist, right, that mimics dopamine. And you add another inhibitor to slow down the breakdown of levodopa. So you just keep adding more and more medications to help manage your on-off times. You've got a lot of pharmaceutical options. They've been out for many, many years, and I feel like they come out with more every year. So I love this graph because this really paints a nice picture of when you start out in early Parkinson's, you've got a really manageable window, therapeutic window, right? So this is your therapeutic window. You take your medication, you're on for a while, you're gonna take another pill at 11, 5, and you're good. 3 pills a day, you're not chasing on time, you feel pretty good with your medication regimen. You can manage it, it's great. Then as the progression goes on, your therapeutic window shrinks, right? and you've got less on time, more off time, and you're constantly chasing that on time. Up and down, and a lot more medications to manage and remember to take. So this is a patient, wait, let's go back. This is with a patient on, right? This is a DBS patient. This is when he's off, the stimulation's off. And this is the dyskinesia right after his medications. So you can see uncontrolled movement. And this is basically just the difference between on and off time. So again, we just talked through it. Always encourage, I don't know if you guys do this yourself, you may do this, keep a journal or a diary to go meet with your neurologist, your movement disorder specialist. You can talk about different changes since your previous meeting with them. They can identify where you are within your disease state and then make some adjustments and changes to maybe your medication regimen and what you may need to improve your quality of life. And that's when a conversation of potentially looking at deep brain stimulation may be discussed. They're encouraging clinicians to talk about this sooner than later. You just need to have symptoms for 4 years. Now, I'm not diagnosed, but symptoms for 4 years to be considered a candidate by the FDA for DBS, right? They can be considered for DBS. A lot of patients have symptoms for many, many years beyond that before they're diagnosed properly. So again, talked about the challenges. Dopamine deficiency grows, becomes more of a challenge to control your symptoms. You've got more fluctuations. And then this is when we start talking about DBS therapy. Have your movement disorder specialist or neurologist mentioned DBS therapy to you before? Most of the people in the room? Okay, that's great. Some people have never even heard of it. So
it's new, isn't it?
it has been out since 1996, and Medtronic was the first to launch DBS therapy. A little bit of history here. We're going back, and when Paul was out in the field. No, Medtronic was first to the table.
A lot of people do say that they'll be amazed with hearing about DBS. It's just amazing how far technology has come, huh?
Yeah, no, it's been out for a while, right? 1996 for sure. And then St. Jude Medical came in, Abbott bought them in 2016, and then Boston Scientific, right behind us. So, oh well, I just talked through that, didn't I?
Good segue.
Right into the calendar. So I just gave you the brief history of DBS. It's very safe. It's been done many years, obviously, over 20 years. And patients have really benefited from this therapy. It's life-changing. So what DBS says, I always say it's electric dopamine for the brain. Right? You're stimulating that area of the brain that's going to help you with movement. It will help you reduce some of those medications. There's clinical evidence, 50%, 60%. Some patients get over 80% reduction in medication once they get DBS. Every patient is different. That's just a range that I'm talking about. So it reduces your involuntary movements. It stabilizes the circuitry in the brain that is affected by Parkinson's. You can change it or stop it any time. It's completely removable. It's adjustable to what you need for your optimal therapy. So that's the great thing about DBS, right? You can change it, optimize it, steer it. We have directionality now. That's new. Abbott came out on the market with directionality in 2016. And what that means is you can steer stimulation to where you need it towards benefit, away from side effects. And we all three companies have directionality now. These are the things that will really respond well with DBS, and it's all having to do with movement, right? So we've got tremor, rigidity, bradykinesia, which is your slowness, akinesia, which is no movement, and then dyskinesia, which is medically induced a lot by the medications you're taking. These are some things that may be less responsive. Some patients get benefits, some don't. So it is less responsive, which is your speech dysfunction, the swallowing, the micrographia, which is the small writing, postural instability and freezing of gait. Now, Some patients may get some benefit, some may not. So what makes a DBS candidate a good candidate? First of all, just be healthy and good enough to have surgery, any surgery. So that's important. We talked about symptoms for 4 years, not diagnosed, but just having symptoms. So that's very different. Okay. The other thing is cognitive impairment. We want to make sure, and one of the steps of the pre-surgical workup is going through a neuropsych test, right? And it can take a couple hours, but they want to make sure cognitively you're in the right place to have the deep brain stimulation mentally. And then if you're still getting improvement from medication, you should be fine. You'll get improvement with DBS. They'll do an on and off test as well. So they'll have you come in off medications, they'll have you do some exercising, they'll do some testing, then they'll have you take your medication, and they want to see that you are responsive. And insurance requires that as well. So the procedure, how it works. Stimulation sends electrical pulses to the lead inside the brain. The lead delivers stimulation to a targeted part of the brain, so the lead goes into whatever target that the doctor decides is the right target for you. It's usually either the STN, the subthalamus nucleus, or the GPI, the globus pallidus. And then that targeted stimulation stabilizes those brain signals that we talked about, right? And that causes the involuntary movement and helps you get control of those involuntary movements. Any questions on this? I think a lot of people, when they hear DBS therapy and brain surgery, it can be scary, right? So they think this big surgery. I've had patients ask me if I saw the brain. I try to describe it as, it's like laparoscopic, almost, like minimally invasive surgery. Yes?
I do have a question. You talked about reversibility.
Yes, sir.
Let's say that the procedure is done, and then one of the side effects is motor, like maybe a speech, impediment or slowness or whatever. Can that be reversed? I mean, when you say reversed, do they actually take the leads out?
So yes, that's what I meant. Is it can be completely removed if it's not bringing you benefit. You can remove the whole system.
Does the side effect go away as it's removed?
Well, yes, if it's causing you that bad of side effect, if you remove the device, it should. Now, however, with the directional leads that we have, when we talked about steering stimulation, if you find that you're having speech issues with stimulation, turn on a certain amplitude, frequency, or pulse width. I mean, there's thousands of programming options. We just simply steer that stimulation away that's causing that side effect.
Okay.
Yeah. So it's programmable. You can steer it away from side effects, which is what's so great about the latest leads that we've got out today versus when they first launched in '96. But then for those patients, which I've not had a patient have one removed, but for those patients that don't feel like it's bringing them any benefit or therapy, it can be completely removed.
So the side effects can be
Correct.
Can be manipulated with different
Yes.
techniques, right?
Yes, very good question. Thank you for asking that. Any other questions about how that works? Yes, ma'am.
I'm not exactly sure how to put this. You said it might have some effect on swallowing, but not necessarily.
It may not help with the swallowing.
Mm-hmm.
So DBS therapy is really, it helps with all your movement.
Mm-hmm.
And some of the things that it may not help with, and that's one of them, is the swallowing.
You say may not help, so
It may not, it's not,
but sometimes it does.
it could help, but it does, there's no guarantees. You wanna jump in there, Paul?
It has a lot to do with, what's causing your swallowing issues. So a lot of times they'll order a swallow test. There you go. If it's related to something that could be movement or muscle related, it potentially could improve, but typically not. The drooling, the swallowing, those are all just very common problems for Parkinson's.
Like we've talked about before, too, there are a lot of benefits to DBS, but speech and balance, knowing where you are in space, are the two things that it doesn't help.
Less responsive to that. So there's a couple of stages depending on the surgeon. Stage one is they always do the pre-op MRI, and they'll do some imaging and planning. They'll do a pre-op MRI and then a CT scan. They're looking for making sure they identify the targets in the brain, the trajectory, and they're going to plan that out prior to. the implantation of the lead. Then during the testing, you can have it awake or asleep. Again, that's a discussion for your doctor. We like to do it more awake, so we can test you and do live testing. So they'll sedate you a little bit, implant the lead, wake you up, and then we're going to ask you questions. I'm going to turn on stimulation. We'll have you do some testing, touch your fingers, touch your nose, repeat after me. We want to check your speech. And we're looking for benefits and side effects and identifying our therapeutic window. Okay? And then once we feel like the lead's, and we know the lead's in a good place, we're going to secure it and lock it down. And we can do that unilateral or bilateral. Okay? Usually it's bilateral. Stage 2 is when you go back in. You stay one night, just one night in the hospital, typically for the first stage. Second stage is outpatient, usually. But they run the lead in the extension to the battery site. So they make one incision back here, they pull the leads down, attach it to the extension. It's all underneath the skin subcutaneously, and they make an incision here, implant the battery, and insert the extensions into the battery, and that's it. And then they close. And then you'll go and meet with your movement disorder specialist. Usually that's about 4 weeks after the procedure, and what they do is they map the leads. So they do a monopolar programming. They turn on your stimulation for the first time. Patients are so excited for that. And they start working their way up the lead to identify the best contacts at the best amplitude, frequency, and pulse width. They're looking for side effects, like you brought up, and identifying how low of amplitude we're at when we see your benefits.
Are you taking any drugs during this 3 to 5 weeks while you're waiting before you do the programming?
Yes, because you're not gonna, you might get some microlesioning effect. We call it the honeymoon period, right? You may, just from putting the lead in the brain, you may get some benefit, tremor reduction, something that helps, that you think that the device is turned on, but it's not. And so that could last a week, it could last a day. But you should be going back on the regular medications. But then when you go in for the day of programming, typically you come in off medication because they want to be able to do really get a good baseline, and then turn on stimulation, map the lead, and then they'll have you take your medications. Because the goal here is to get the right balance of medication and stimulation. So, and then after your initial programming, they'll have you come back because they really want to optimize your care sooner than later. So they'll have you come back for a few courses of a couple of weeks, and then you'll start, once they get your care optimized, you may come once a quarter. Cost and coverage, Medicare and private insurance is covering this procedure, minus any deductibles that you may have. This is not a cure. I just want to make sure that, this is a great therapy for patients. It changes patients' lives. Patients get their life back. Patients that used to paint or teach, play a musical instrument, they've been able to regain the ability to do the things that they once loved doing. But it is not a cure. DBS has the same risks as most any surgery, right? So any complications, side effects. I think the most common is infection and maybe bleeds, but they do a post-op CT scan and check for that. And I can tell you my surgeons are very, very meticulous when it comes to being sterile. So, and then just a little bit about DBS with Abbott. We covered what the device consists of. So this is the burr cap. This is the extension, and the leads are here. This is the directionality of the segments on the leads. And then we are partnered with Apple. So everything is on the Apple iOS platform. It's all Bluetooth. You get an iPhone as your patient controller, and the clinician has an iPad. That is not an iPod.
Something.
Right. And then directional therapy, we talked about that. So this is the directionality of the leads, precisely targeting the area of the brain to give you the best optimal care. So that is exactly what Abbott's directional leads do, or directionality in general. So this just shows you how you can steer the stimulation, and the blue part is the target of the brain. And we're always trying to get the directional part of the lead in the sweet spot of the target, right in the middle, so it gives us more programming options. Yeah, we talked about this. Yeah, so we have a recharge-free battery, so there's no burden of having to remember to charge. We just had clinical evidence come out that our batteries on average last over 5 years. 50% of the batteries lasted over 5 years. We followed the first 5,000 patients implanted. We pulled patient tracking data. We looked at all the Epic data within the hospital systems. And so over 50% of the patients after implantation lasted over 5 years. Again, no worrying about charging. You just set it, forget it, and focus on getting your life back with DBS. Controlling every day, you've got your smartphone right at your fingertips with the app right on it. That's your controller. That's all you have to worry about. And not even worry about it, it's on your phone. So it's right there at your fingertips. And then we've got a lot of things that we're working on as far as wearables and those things when it comes to digital care that will track tremor, dyskinesia, etc. And that's coming soon. And that's it. But I have a special treat too. I wanted to talk to you about, well, actually, let me talk about one more thing. One of the main things that Abbott has is virtual clinic. How can I forget that? We're the only company that offers telemedicine to a point, right? It's the face-to-face telemedicine call with your doctor, but they can actually program you no matter where you are. I have patients that live in India for half the year that are programmed by doctors here in Dallas. Okay, if you travel a lot, this will give you your life back. You may start traveling again. And so if you need to connect to your doctor just for a 15-minute check-in, they can adjust therapy, and it's all from wherever you are, right? So it's completely virtual, real time. And this is an example of what that looks like. So the clinician's talking to you, they can see the lead, they can see everything and adjust your stimulation as well.
Question.
Yeah.
So what if you lose the phone?
We replace it.
And so you can just attach to a different phone or connect?
True. So the one we provide for you, and if you lose that, then if you already have an Apple phone, you can just, it's on the App Store. So you just download the app on the App Store. Yeah.
Okay.
And any Apple device, actually. Well, the iPhones and the iPods, for now. Yes.
This may be a real picky question, but what length of time does Abbott have under contract with Apple? So the technology moves together,
Yes.
and that Apple doesn't go this way, and all of a sudden there's a problem with Abbott.
We are bind and bound in this contract with Apple. We have so many different platforms, like different devices we're working on together with technology and research and development, that it's a binding contract. I don't see us ever going away from our partnership with Apple. I mean, that's just the virtual clinic piece alone, to get that through FDA approval with all the confidentiality, and it's a very secure back-ended network. It's a lot of work that went into that. The Apple Watches, things like that, that we're all seamlessly integrated with. And from a data perspective, that's a good question, but we don't foresee that ever changing. I mean, that's our platform. Our whole device is the Apple iOS platform and Bluetooth.
They have, well, it's a picky question, but, so I'll leave it.
We could talk about it more offline.
Sure.
So this is just talking about the secure connection I was just mentioning. How simple it is. It's a bonded IPG, which is what your battery is called, an IPG. And you connect to your clinician. It's very simple and easy. You need to have Wi-Fi. And that's it. I want to get a patient. I want to talk to you about Sean Connolly. She's here today. We implanted her last year. And I wanted her to come up and share her journey and her story with you. I think it will really resonate more than me standing up here talking to you about DBS. So Sean, will you come up? Thank you.
How's everybody today?
Good.
Good. So I was diagnosed with Parkinson's about 5 years ago. Looking back on it, my symptoms probably started over 10 years ago. I'm 51 now, in case anybody was wondering. But I had gotten so bad that I could hardly walk. I had to move in with my parents because I could no longer wash my hair. I could no longer cut my food. I have 2 grandchildren. I have a 2-year-old and a 4-year-old. and I could not get on the ground with them, I could not play with them, they would bring cars up to me, I just didn't have the strength in my hand, or the tremor was so bad, should I say, I couldn't function. It was really bad. I was renting scooters, my kids were having to push me around in a wheelchair, it was really not pleasant. About a year ago, I think it was June, I had my first surgery. July, I had the second surgery where they implant the generator. And a few weeks later, they turned me on. And literally within 5 minutes, life-changing. Life-changing. I ran down the hallway at the doctor's office. I can now get out, play, run around with my grandkids. I'm not scared to travel anymore. We went to Supercross last weekend, 2 weeks ago. I took a cruise. I'm doing things that over the last 5 years, I just put my life on hold and just pretty much wasn't able to get out of my house. And now I'm back to doing everything. DBS has changed my life. It's given me my life back is what it's done. So I encourage you guys to talk to your doctors about it. If you're a candidate, I say go for it. Take life by the hand and run with it, because it's just, I cannot say it enough. I wouldn't be making memories with my grandkids and taking my grandkids by myself. Oh, this is one thing. I couldn't have my grandkids by myself because I couldn't do the car seats. Now, Mimi gets to be a Mimi and I can take them with me right now, so I'm loving it. Like I said, it's almost been a year. I wish I'd done it sooner. I wish I'd had somebody talking to me about it. But yeah, that's where I'm at today. I can run out, go get food, carry all kinds of stuff now, and it's just been amazing. So,
We're going to talk about your experience at virtual clinic.
oh yes, virtual clinic is a huge thing. I love it. Oh, yes. Actually, today, I have a virtual visit with my doctor here at about 1:30 or 1:40. So I will just log onto my device, click this, start virtual, and my doctor will be right here, so I can do it right from this room. And he can adjust my settings, because like Melissa was saying, DBS is not a cure, but it does help tremendously. So I have to do an adjustment because I'm having a little bit more of my tremors coming back. Nothing significant, it's just gonna be a little adjustment. But I'm able to do that, but my life is not put on hold. I do not have to worry about, oh, I can't go do this with you on Friday because I have to run to the doctor, and that takes up your whole day usually. Nope, I'm here, I'll take 15 minutes and it'll be done, and my settings will be changed. That's the other thing, is like going out of the country. I feel very comfortable going out of the country or taking trips anywhere, because if I have an issue, my doctor is literally just a phone call and a button push away to where he can physically see me through this and go through our testing and adjust anything that needs to adjust. So it's been a real sense of security for me, knowing that I can do this. And I think somebody was asking about if they lose it. I'm the world's worst at losing stuff. It is just an app. So I have it on my iPhone too. I was originally given an iPod, and for personal reasons, I keep them separate, aka Mimi lets her babies play with her phone, and I don't want them to get a hold of my app. So I keep this app kind of over here so I know it can't get messed with. When the doctor was actually talking to me about doing this surgery, he'd given me a couple choices, and originally I had wanted to go with the rechargeable, because it is a smaller generator. And I don't know if any of you guys can see, I am a little bit different. I've had a double mastectomy, so I don't have any tissue up here. So my generator is very visible. Most people it wouldn't be. But the option for the chargeable generator is about half the size of Melissa, would you say? And so originally I had wanted to go with that, and after discussion, because beforehand, let me back up, I was sitting at home and I'm thinking, oh, no big deal, I can charge it once a week, sit, charge it, charge the device, to charge the thing that you wear, to charge your generator. Well, I'm so glad my doctor and I discussed it more, and I went with the set it, forget about it, I won't think about it for at least 5 years, or probably 4 or 5 years, something like that. The doctor can check it all the time too, when he can check the strength of my battery, but because it's given me my life back, I'm so busy, I cannot imagine slowing down now to charge it. So I love the fact that this is a 5-year battery. I don't have to think about it. I mean, and on my cruise, I can't imagine being away for 7 days and having to worry about charging something either. I do good enough to charge my phone, let alone something else. But it's been life-changing. What Abbott offers is just hands down, for me, life-changing. And Melissa, thank you. She was in the surgeries with me. She was in my programmings with me. I've made a lifelong friend. She held my hand when I was terrified through surgery. So it's been amazing.
Where did you have your surgery done?
I did my surgery at Baylor, downtown Dallas.
Okay.
Yeah, and Dr. Biddy Walla was my surgeon.
Okay, thank you.
So, but I am a completely open book, so if anybody has any questions about anything.
You mentioned, well, no, you didn't mention, it was exercise. I mean, they talk about, they want to make sure that you're as healthy as you can be before you go into any surgery, but do you have like a regular exercise regimen that you go through, and was it the same after you had the implant?
Okay, so my story is actually really kind of complicated. Right before I did this, I had to have my entire colon removed. I had to have a double mastectomy, and I had some pretty major health issues going on that did not allow me to exercise. Then I was diagnosed with the Parkinson's, and it really just honestly kicked my butt. I was not getting out of the chair because I couldn't physically move. I also had this the tachycardia, where if I did get up and walk, my heart rate would jump to 200. So, but now, I would say probably 3 months after I was turned on is when I noticed a difference right away. Like within 5 minutes of being turned on, I noticed a difference. But me physically and able to exercise, about 3 months of my body healing and everything, I really started to feel good. 5 months, can't stop me, and now I can go walk 7 miles a day now, which no way I could have done that before, no way. I can get up and go run with my grandkids, which they have me do quite often. So.
Thank you. Any other questions?
Now, you've got a virtual clinic, so you're in connection with a neurologist.
Yes, my movement.
Who's trained in the DBS.
Yes.
Right.
Yes.
But then you have a local neurologist that you see for anything, or is it just strictly?
I just use for me personally, I went with a neurologist that is a movement disorder specialist. This is what he does.
But he's quite attuned to DBS, because
Yes.
I don't think all neurologists, movement disorder or not, are really aware or not, to the details.
Right.
Well,
all I can do is tell you that my doctor is Dr. Elkert out of Baylor, Dallas. He is absolutely amazing. He hears me, and that's a huge thing. you have to build your team. Let's face it, guys, with Parkinson's, you have to build your team. So this is my team that I have built. Is Dr. Biddywala is my surgeon. Melissa is my drug rep app for my system. Dr. Elkert is my movement specialist disorder. And then I have the team on like my primary and so on. But we are all on the same page. But in order to be successful, not just with DBS, I say in your healthcare journey period, you have to build your team and ask your doctors questions. Just ask, and you have to advocate for yourself. And I didn't like my first couple of neurologists I went through, and then I found Dr. Elkert, and he has been, he's part of my life-changing team. So.
I think we have one more question.
Well, this is for you.
Oh, for me.
What's the difference between the Medtronic and the Abbott and Boston? I mean, isn't it all the same?
We have different features and functionalities. We all have directionality, right, on needs. We do not have a rechargeable right now, so we just have the recharge free. We have the virtual clinic. That's another feature that we only have. They have rechargeables. They've got different features within their platforms that they offer. So from a programming standpoint, et cetera.
But, okay, if I'm going into the doctor and they go, you're going to have the DBS, do you get a choice of which?
Absolutely.
You should.
I want to answer that if I can, and I
Yes,
don't mean to step on
please do.
anybody's toes, but as a patient, you have the right to pick whichever system you feel works best for you.
Yes.
And that, you guys, you can't forget that. If your doctor is not comfortable with one because they just haven't used it enough, and you like something and you feel this is gonna benefit you more, then go for it. No matter which system you choose, DBS is gonna be life-changing. But you have to advocate for yourself, and you have to pick what works best for you.
Yeah. Do your due diligence, because a rechargeable may be the best fit for patients, and we don't offer one, right? And a non-rechargeable may be a better fit for a patient, right? And we have data that shows that we have a very long longevity of our primary cell recharge-free batteries. So you've got to do what's best for you in your lifestyle, for sure.
Another question that, and I'm just throwing this out there because I've been asked this by several people. They always ask, get a lot, do I feel my wires? No, absolutely not. I can turn my head all the way left, right, all the way around, and and my wires run down this side, down through my generator.
But is it similar to pacemaker lead recovery time, or is it?
I'm not familiar with this big early recovery time, but,
I can tell you my recovery time was, I'm almost positive it was like 6 weeks of nothing over 5 to 8 pounds, I think is what it was. And I could be wrong, but that's definitely, if you do it, that's between you and your surgeon. But it was about,
Similar to pacemaker.
about 6 weeks. Then after that, it was like normal lifting, and I could start doing stuff pretty good. And it was about that.
You get back to driving in about a month, no planes for about 6 weeks. That's about the only big restriction you can't think of, you shouldn't be taking a flight.
And no swimming.
So, Miss Melissa, how many patients over the age of 75 have had a successful operation?
oh gosh. Let me Google that. No, I mean for DBS specifically. We just implanted a patient with DBS in her 80s. So, it's not really age, it's not about age for DBS. It's really about how you are in the progression of your disease, if you're still getting benefit from medication, if you're a healthy candidate for surgery, and if the neurologist and the neurosurgeon think that you will benefit from implanting the DBS therapy, right? They're not going to do it if they don't think you're able to handle that. But it's not about age. I mean, Paul, if you want to chime in, or Linda.
I agree.
Yeah, it's,
We've turned away patients that are in their sixties and just not helping people.
Right.
I've been
Okay.
to the 92-year-old.
yeah,
So we've got a wide range.
and I bring up just one other thing, there's a window. I wanted to talk about that window real quick. Which is why I think it's important to talk about patients early on in the diagnosis, so knowledge is power, right? So you know all your options at the forefront. Waiting to talk about this too late, you may miss your window to be a candidate for DBS, and you've missed the opportunity to get back the ability to do things that you love to do. So when the doctor comes to you now, and our clinicians are really good about that now, is talking to you about it sooner. If they bring it up to you and they say, you know, now's the time to really consider this, I would listen to them. Because a few years down the line, you've lost 5 years and the ability to get it all together. So I've seen it happen, so.
Melissa, can I add to that?
Sure.
Something else to consider too, or just think about is, if your doctor's recommending it to you, it's because they think that you're a good candidate for it. And before the surgery, there's gonna be a lot of checks and balances that take place to make sure that you're a good candidate and that you're gonna be better off having the DBS implanted in you. So even if it's something you wanna do, these checks and balances along the way, like neuropsych testing, on-off testing for medication, even sleep testing, will help to know if it's a good thing for you. So you don't have to worry about whether it will make you worse or not help at all. A lot of people worry about that. It's a big surgery to decide to have or to not help at all. So if you get through that process and they say you can move forward, you can feel confident knowing you're the right person for it.
And that kind of ties into the next question. So that being said, that you're a good candidate, how many pre-op visits for psychological testings and physical exams are needed before doing the actual surgery?
So they want you to do a neuropsych test, and depending on where you go, it could take hours. I've had people tell me it takes 4 hours, I've had 2 hours. I don't know if the doctors are going to, but the neurologist will send you to a neuropsych doctor, and you'll go in and they'll ask you a lot of questions. And they're determining from a cognitive perspective where you are, and if you would be a good candidate and could handle the DBS surgery. The other thing that they do prior to DBS surgery is an on and off test, which Linda just talked about, and I mentioned it earlier. They'll have you come in completely off your medication, right? And they'll do some movement testing with you, and then they'll have you take your medications, which, and once they've kicked in, sometimes it's about a half hour depending on the patient. And then they'll do the same movement testing exam again to see that, yes, you're still getting movement benefit from your medication, or no, you're not. If you're not, then you're probably not a candidate for DBS, right? That's why you have to do the on and off test. Anything else you want to add to that?
No, so it's
Those are the main two.
Those are the main two, but I mean, your surgeon is evaluating you to make sure, one, you're a good surgery candidate, and also there's the DBS portion of it, right? So sometimes they may ask for different studies, like a sleep study, you'll do blood work, some other things like that. So cardiac clearance.
Oh, that's the pre-op, sorry, yeah, so that's another appointment. I thought it was just related for DBS, so yeah.
But this is all, I mean, it seems like, man, this is a lot, but it's all good stuff because they're looking out for you in the process, right? So DBS related, probably two visits. Overall, probably like 5 to 7, because you have your consult visit with your neurosurgeon, your on-off testing, and then your neuropsych, in addition to whatever the surgeon may want.
Those were it.
Yeah,
Thanks. All right, guys, thank you so much. Again, I love being here today, and thank you, Linda and Paul, for chiming in and us doing this a little bit like a team here, a team effort. We all believe in DBS therapy. We know it helps patients. All of our systems work, and we help patients around the community and all over the world all the time. So if you have any questions for me, for us, please let us know. And Sean is always here as a patient advocate and an ambassador to answer any questions as well. So, thank you.
Thank you, Abbott. Thank you, DBS.